Welcome to this first session of EUS World. This is a webinar we have been planning from the India EUS Club for last 3 months, and we are happy with the response. As of an hour back, I think we had close to 800 registrations. So I think this is something which interests people. Uh, and what I was very happy about it is that we approached our friends all across the world, and all of them immediately agreed that they will participate despite their busy schedules. So, at the beginning, what we will do is I will like to introduce, we will start from Far East, I mean from Australia, Asia, go to Middle East, go to Europe, and then end up in USA. So let us start with Australia. Professor Vipul Agarwal is the president of GISA, current president, and he agreed to be part of it along with Dr. Saurabh Gupta. Vipul, I think, is in South America traveling somewhere, so he could not join. Also, the issue of time, it must be midnight there, but thank you very much, Vipul and Saurabh, for participating in this. Then, of course, we have Professor Nonthalee, who immediately agreed to join. She is representing the TAGE, Thai Association of Gastrointestinal Endoscopy. As you know, Thailand has phenomenal endoscopists and endosonologists. So a strong group is also present today. Um, from Singapore, we have Chris. Chris Kaur is a well known personality around the world. His great work in EUS for many years. We know him well. Mm, Chris, would you like to say a few words?
Just unmute myself. Thank you, Vinay. It's such a pleasure to be part of this huge initiative, and I really thank you for inviting me. So all the best, and
Thank you. Nontali,
yeah.
few words.
Yeah,
Nontali.
it's my pleasure to be part of this program, and I want to thank Vinay for allowing the Thai Association for GI Endoscopy to be part of it. I have more of my colleagues to join in the future, and I want to welcome everyone to the first webinar today. I
Thank
hope you enjoy.
Thank you. Thank you. From Hong Kong, we have Anthony, who is representing Asian EUS Group. Asian EUS Group, as you know, is the mothership for all of us, and we have been part of it for more than a decade, and it is doing great work in education for diagnostic and therapeutic EUS. So, Anthony, I don't know whether he has joined today. Anthony? No. So,
Also,
okay. We have Shannon representing Hong Kong, who will be talking live later, and Nonthalee will introduce her. And then from Indonesia, we have Rinaldi Lesmana. Rinaldi is a hepatologist, but has a great interest in EUS and has published many papers. Rinaldi, are you there?
Yes, thank you, Dr. Vinay.
Uh,
It's my
few
pleasure.
words from you.
Yeah, it's my great pleasure and thanks to be invited for this. I think is very interesting and I think will be a very useful meeting for most endoscopists and endosonographers. This was first time for me, but uh, you always support me every time, whenever, and always encourage me to join over everything and every meeting regarding the development and the innovation of EUS. So I hope this will be the very good start, and then we will continue next time. Thank you,
Thank,
Dr. Vinay.
thank you, Rinaldi. Thank you. We have from UAE Dr. Yogesh Shastri. Yogesh is there? Okay, he's not there. From Egypt, we have Professor Hussein Okasha, very, very well-known endosonographer around the world. He is also busy in Manchester, I think, doing a live program right now. So probably he won't be there. From Saudi Arabia, we have our friend Professor Abid Al-Hibi. Half of these people are actually right now doing live in Manchester. Abid, are you there? Has Abid joined, Anirudh? No. Okay. Coming to Europe, we have Professor Paolo Archidiacono. You know him very well. He does every year a big conference called EUS. We have, of course, Carlo is going to help us later with the live. And Claudio. Claudio has been at the forefront of EUS for many decades now. He conducts conferences, educational programs, and he founded EGEUS, the European EUS group. So he's representing Claudio. Are you around? Okay, I think not there. I think that.
Okay, yes, I'm here. Thank you very much, Vinay. It is really a honor, before than a pleasure for me to accept your invitation to participate in this initiative of the Indian US Club. The idea to create an online program to make the US education and training easier and make it accessible to many young guys, and also no longer young, but interested in expanding and improving their US practice, is a very big, great idea. Thanks to your great charisma as an UX expert and trainer, you quickly brought together a large number of well-known international experts, and this adventure begins today. Thank you very much.
Thank you, Claudio. Thank you very much. We moved to UK, and UK we have Dr. Manu Nair, a very, very well-known, established endoscopist and endosonographer, regular publisher, has published a lot on lamps. Manu?
Yes, thank you. Thank you, Vinay. I think as the rest of the faculty have said, it's a real honor, and I feel privileged that I'm part of this stellar group. And you know, when you send the invitation, the idea and the initiative that you have for this particular meeting is quite unique. And this is what I think will make this meeting a success. So yeah, looking forward to not only today, but also future meetings. As you rightly said, many of us are involved in the Manchester meeting. So I'll try my best to stay in the meeting for the rest of the evening. But thank you once again, Vinay.
Yeah, thank you. So Manu is the chief of the UK Interventional EUS group. It's a very active group, doing lots of educational programs in UK, and fantastic work is being done there. So congratulations on that, Manu.
Thank you. Thank you.
Is Nadeem there? Dr. Nadeem Tehani, again from UK, a good friend. Nadeem, I think, must be busy with your Manchester program.
Yeah, I think he was just following because I finished ours half an hour ago. So he was doing his last case. I suspect he's busy.
Fine. So let's change continents and move to US. We have two great friends from the city of Orlando, Florida. Professor Mohammad Khalid Hassan from the Center of Interventional Endoscopy. Khalid Bhai, are you around still?
I'm still here, and internet is still working, so that's good. And I'm supposed to be in Orlando, but I'm on a cruise ship in Alaska. And but Vinay, thank you so much for getting everybody together. This should be a phenomenal educational course. For the beginners, for the experts, what that happens is like even even though we have done so many cases, still there's always nuances, and we learn from each other. And this, beside being educational, it's an opportunity for us to connect with the rest of the EUS world, and for future have research projects, and overall, it's really, really good to have everybody together. So thank you so much for getting us together on this platform, and it's really good to see everybody.
Thank you, Khalid Bhai. Thank you very much. And from the same center, we have Dr. Kambij, a very, very young, innovative, enthusiastic endoscopist, really, really proud of the quantum of work that he is producing from CIE in such a short time. And he will be, of course, later giving us a little review or this thing of the technique that he has along with Khalid Bhai. Kambij,
good morning, everyone. Thank you, Dr. Dhir. I just will echo the sentiment that most of our colleagues have put out there, which is it's fantastic to have someone like you that's been a sort of a guiding star and a mentor lead a program like this in an area that is of tremendous interest to younger endosonographers. So it's a great initiative, and we're encouraged and privileged to be part of it. Thank you.
Thanks, Kambij. I see Saurabh from Australia. Saurabh, can you hear me?
Yes, I can indeed, Vinay. How are you?
Wow, Saurabh, what is the time there?
Just 10:15 in the evening.
Oh, okay. You're on the
Early
great,
still.
great. So I introduced you and Vipul in the beginning. So few words. Saurabh is a close friend, does great work in EUS, interventional EUS. Few words from you before we start.
Oh, no, fantastic. I can just say that echo everything that everyone else has said. It's fantastic to be part of this, and a great honor to be considered an expert, even though I'm not anywhere near the caliber of many others in the screen that I can see.
Well, I'm not like that.
And we look forward to having you here for our next meeting, Vinay. Unfortunately, you couldn't attend the last one, but we'll get you back here again.
Thank you, Saurabh. Thank you. Anirudh, can we have a short video introducing you all about
Sure.
2 minutes? Yeah. Thank you very much. And I think now I'll hand over to Sandeep and Nonthalee for conducting the rest of the program. Sandeep, Nonthalee, yeah.
Hi, thank you, Vinay, and thank you everybody for joining in. And let's start the proceedings. I am Sundeep Lakhtakia from Asian Institute of Gastroenterology in Hyderabad, India. And with me is my dear friend, Dr. Nonthalee, who will be moderating the session together. Nonthalee, over to you, and you can introduce the first speaker, and then we can start off.
Sure. Thanks, Sundeep. And again, I'm very happy to be here to see everyone here. And I have the pleasure of introduce our first speaker, my dear friend, Dr. Shannon Chan. Shannon is currently an assistant professor and division chief of the upper GI and metabolic surgery of the Chinese University of Hong Kong. And today, Shannon is going to talk about EUS-guided gastroenterostomy current evidence. Please, Shannon.
Thank you so much, Nonthalee, and also Vinay for your kind invitation. So let me share my screen. Let's see. Okay. Can you see my screen?
Yes, we can.
Okay. So since I've only been given 10 minutes to talk about the current evidence of EUS-guided gastroenterostomy, so I've only chosen the papers with the stronger evidence, and I will not talk about, case series and stuff, but I'll only talk about comparative studies and the available RCTs. So we all know that to palliate GOO, there are three ways. So either a surgical gastroenterostomy, which is usually done laparoscopically by surgeons, and the other is a endoscopic duodenal stenting, which is a relatively easy procedure with low morbidity. However, the stent patency is a big problem. And the third is the topic of today, the EUS-guided gastroenterostomy. So the good thing about a surgical GJ, of course, is its long patency because it's done away from the tumor. It can be done in the same session as a staging laparoscopy. However, it is quite invasive because it's surgery. It requires general anesthesia, and there is, although it looks very simple, there is a problem mainly a lot of times there's a kinking of the GJ, and in non-draining GJ, if there are any surgeons in the audience, you know that there's like a real life challenge to these non-draining GJs, and because of this, the hospital stay is usually longer. And because the OT, the operating theater is required, it is usually also more expensive. So duodenal stent, we know it is very cost effective. However, its patency is quite low and with a higher rates of reintervention. And if you use a fully covered stent, there is always a chance of stent migration, especially nowadays when the chemotherapies and immunotherapies are so effective. The tumor shrinks and the stent may be migrated. So EUS-guided GE is probably theoretically the best of both worlds because the stent is inserted away from the tumor. It can be done endoscopically and with a faster recovery. However, the problem is that it requires expertise because the complications may be difficult to salvage if you're not an expert, and this is probably why Vinay chose this topic today to discuss on difficult GEs. So this is a systematic review and meta-analysis comparing EUS-GE stenting and surgical GJ. So you can see that the technical success rate is quite similar. And the clinical success rates are also quite similar. However, the recurrent GOO rates, the EUS-GE has a much lower rate when compared to duodenal stenting. And for procedural complications, you can see all three arms are quite similar. So this is a meta-analysis and systematic review of some retrospective case series. So then comes the next, the 3-arm retrospective comparative study, which is done between our center and also Vinay Center. So we compared retrospectively all the EUS-GJs that we've done. So at that time, all 30 were done with the EPAS balloon compared to laparoscopic GJ and SAMS. So you can see that procedural time, of course, a surgical GJ is the longest. Hospital stay too, surgical GJ has associated with a longer hospital stay. And for SAMS, the recurrent obstruction rate is much higher with higher reintervention rate. The 1-month GOO score, which is the consistency of food the patient can tolerate. Usually it's 1, 2, 3, fluid, solid, full fluid, soft diet, and solid diet. You can see that for laparoscopic GJ and the EUS-GJ, patients can tolerate solid diet for a longer time. And so with this comparative study, we concluded you can see that EUS-GJ has probably the best outcome of them all. However, there's still a retrospective comparative study between the 3 arms. So then comes a level 1 evidence, which is published by Dr. Anthony Teo last year in Lancet, comparing EUS-GE versus duodenal stenting. So in this RCT, of course, palliative cases were included only. The primary outcome was re-intervention at 6 months. And you can see that the re-intervention rate of duodenal stenting is much higher than that of EUS-GE. And also the stent patency. And you can also see that the 1-month GOO score is also significantly higher in the EUS-GE group, while at the same time not increasing the adverse events rate. So you can also see very clearly in this Kaplan-Meier curve that the duodenal stenting group has a much lower stent patency. But then some people will ask, is 6 months too long a time to discuss re-intervention, because a lot of these patients are palliative in nature. So if a patient is only going to survive for 3 or 4 months, is it still worth doing an EUS-GE? So there is still a cost-effective concern, but the evidence is that clinically, EUS-GE has a much better clinical outcome when compared to duodenal stenting. And you can also see from the guidelines, international guidelines, that EUS-GE has now been incorporated into international guidelines as an alternative, or one of the options to palliate GOO as compared to enteral stenting or surgery, but in an expert setting. So hopefully by the end of today, we will learn together with all the experts here how to turn ourselves into experts and how to avoid complications. So of course, we know EUS-GE now, clinical outcomes is better than duodenal stenting. So how about when we compare it to surgical GJ? So in fact, this year at DDW, there is very exciting presentations on 2 RCTs comparing EUS-GE versus a surgical GJ. So the first one is done by Shyam and also G's group from Orlando. So again, they included only patients with unresectable pancreatobiliary or gastroduodenal malignancy. The primary outcome is a little bit difficult to interpret, though. It's a composite outcome, including the inability to tolerate soft diet prior to hospital discharge, the need for surgical or endoscopic re-intervention, or the need for supplemental nutrition or procedure-related adverse events. So it's like 3 different factors adding together as a composite outcome. So 74 patients were included, and you can see that the primary outcome is more commonly happened in surgical GJ. So meaning that the surgical GJ had more patients who were not able to tolerate soft diet at discharge, had more increased need for re-intervention, or the patient required more need for supplemental nutrition or more procedure-related adverse events. And if you do look into the outcomes one by one, you see that more surgical GJ patients cannot tolerate soft diet at discharge, and they require more re-intervention. And so this was not available as a full publication yet, but it was presented at DDW. However, one of the points to discuss in this trial is that the conversion from laparoscopic to open is more than 50%. So I'm a surgeon myself, so I'm a little bit skeptical about this conversion rate. However, during the presentation, G did mention that they did a post hoc analysis showing that there was no difference in the outcomes between the open and the minimally invasive group. So perhaps we will need to look into the full publication before looking into this conversion rate. But the evidence now is that surgical GJ has a better outcome than EUS-GJ. The second RCT, which has a very, very similar outcome and also inclusion criteria, is published by a Netherlands group The trial is called Enduro. It's a RCT across Netherlands. There are two primary outcomes. So first, it is a superiority outcome, which is the time to solid oral intake. And the second outcome is a non-inferiority outcome, which is persistent or recurrent obstructive symptoms requiring interventions at 6 months with a margin of 20%, which is considered non-inferior. So around 100 patients were included, and the median time to oral intake was 1 day versus 3 day with the EUS-GE faster time to oral intake. And as in re-intervention, the re-intervention rate is also in favor to EUS-GE. And clinical success, median length of stay are also superior in the EUS-GE group. So hopefully, if these two RCTs are published, that we have more evidence to conclude that EUS-GE is superior than surgical GJ in terms of palliation for malignant GOO. So these are the clinical outcomes. So there is also a paper published by Moen on the learning curve. So how many cases do you need as an training in order to become proficient and mastery? So in fact, this is Moen's own learning curve. So he was already an expert when he started to do EUS-GE, but you can see that it still took him 25 cases in order to be proficient and 40 to be master. So maybe we can take this as a reference on how many cases that you require proctorship before doing the procedure independently. In terms of the different techniques, we know that there's mainly two techniques nowadays, the direct puncture technique, which is more commonly used, and also the EPAS balloon. So the EPAS balloon was invented by Itoi Sensei. So I'm sure all of you know about it, where a catheter is inserted where there are two balloons inflated, and we distend the loop of small bowel between the two balloons, and thus provides a very stable platform for EUS-GE. And if you don't have the EPAS balloon, which now is only available in Japan, I believe, you can use your own way to do it, which I think is how Nonthalee does her EUS-GEs, is that you can ask your vascular surgeons for aortic balloon. So the quarter balloon, in this study, they used two, but in fact, you can also use one aortic balloon as a distal obstruction, where you infuse the proximal part of the small bowel to achieve also a stable and distended platform for EUS-GE. And then, of course, comes Yenny Chan's a new through the scope double balloon, where you can cannulate first, and then you can insert his catheter through your OGD scope. And because this 4-channel at the end, it can be exchanged. It can be removed from the catheter itself. So after you exchange your scope out, you can in fact insert these 4 catheters and attach it to the catheter, which is connected to 2 balloons. So with these 4 channels, you can distend the proximal and distal balloon. And the 3rd channel is to infuse and distend the water in between. So it actually works very well as an EPAS balloon, but it is a through the scope EPAS balloon. So of course, there are no direct comparison between these balloon-assisted techniques and this direct puncture method, which I'm sure experts will talk about later, where you infuse the jejunum with saline, contrast, indicocamine, and also buscopan or glucagon. So in fact, our center has done a retrospective comparison in the 2 different techniques, the EPAS versus the direct puncture. So we had the honor of using the EPAS balloon for our previous RCT. However, after the RCT, we changed to the direct puncture because of the lack of EPAS balloon. So you can see the direct puncture as compared to EPAS, the technical success rate is very similar. The clinical success, again, is quite similar. And in terms of the adverse events, the direct puncture had 2 adverse events, while the EPAS only had 1. And so, of course, the sample size is relatively small, only 27 versus 38. But then we concluded that with the EPAS and direct puncture, there is no difference in clinical or technical success. However, the problem with this study is that we only started to do direct puncture after we have mastered EPAS technique. So then we have surpassed the learning curve with the EPAS before we moved on to direct puncture. So this might not be applicable to new beginners, and it is a relatively small sample size. And in terms of what size of stent to use, there is a comparison between 10, 20 millimeter and 15. And you can see that with the 20, patients can tolerate solid and complete diet as compared to the 15. So perhaps if you can, you should use the 20 mm lamps. And then, of course, the last publication talks about the complication, type 1, 2, 3, 4. I'm sure we will touch on it later today, so I will not go into details because I guess I'm running out of time. So in conclusion, EUS-GE is a safe and feasible procedure for palliation of GOO. That there is level 1 evidence showing that EUS-GE is superior to duodenal stent. And if the 2 RCTs are further published, there will also be level 1 evidence showing that EUS-GE is superior to surgical GJ. However, more studies on cost effectiveness is required, and the use in benign indications is also in evaluation. Thank you.
Thank you so much, Shannon. That was excellent. And let me just remind the audience that today we will be talking all about EUS-guided GJ. We'll start with Shannon talking about overview and the current data. Then we'll show you live demonstration of how an expert would do EUS-GJ. And then we'll talk more about difficult cases of EUS-GJ. So I want to encourage the audience to send their questions to the Q&A box, and we will try to answer all the questions as we go through our 1 hour and 15-minute webinar. Shannon, I'm gonna keep you here for now. I think that we have a live demonstration coming up next, and Professor Carlo, I see you and your team on the screen. I'm guessing you're ready to go. So Shannon, stay with us, and we'll have you answer some of the questions later on. So I have the pleasure of introducing our next speaker, moderator, faculty, Professor Carlo, who really no needs introduction, but Professor Carlo is the director of Gastroenterology and Digestive Endoscopy from Italy, very well known. And I want to welcome you to the first webinar on board EUS. If you are ready to go, please go ahead, start with the case. We can see you, but we cannot hear you.
Can you hear us?
Oh, now we can hear you very well.
Yeah, so good afternoon. It's a pleasure for us of being here with you today, the Forli team. So I'm going to present the case of this patient. He is 83 years old male, which had a history and a diagnosis at least 1 year ago of an pancreatic adenocarcinoma, which underwent to an EUS-guided biopsy and a biliary intraspapillary with a
I think we're losing your audio.
May I request you to start live, and probably we can intermittently talk so that we save time.
An infiltration of the duodenum due to a disease progression. As he had a cholangitis, we perform at least an attempt of biliary drainage, but due to the infiltration of the papillary area, we were not able to reach once again the metal stent. And so we moved for an EUS-guided biliary drainage. And the only way we were able to drainage this patient was to perform an EUS gallbladder drainage as rescue, because the common bile duct wasn't so dilated. It was 11 millimeter, and the intrahepatic duct were at least not dilated, so 2 millimeter. So we verified for the patency of the cystic duct, and we moved to a gallbladder drainage. So here you can see probably the X-ray, and where you can see both stents, so the transpapillary one. I don't know if you can see the X-ray at least.
Yes, we can see X-ray and we can see EUS
Okay.
image.
So I think at an X-ray you can nicely see the 2 stents already placed.
Yes, we can see that.
Okay. Hi, I'm Carlo Fabbri.
Hello.
La telecamera in sala. Okay. Hi, I'm Carlo Fabbri. Hello. First of all, I would like to say thank you for this kind invitation in this amazing course. I think that to have an opportunity to share together a so challenging procedures in so complex patients is a really step forward for us to discuss together about this technique, and in particularly about the clinical impact and the role of interventional endoscopy in our multi-professional team discussion. If I can switch in fluoroscopy, as Cecilia Binda told us, we can see very well the first tubular stent and the second one, a LAM stent, that is the result of impossibility to perform an hepatocogastro procedure due to the lack of dilation of the biliary tract. Now we can see also the OEC catheter, the orojejunal catheter, that we loaded just a few minutes ago, and he is positioned in the traits area, and so we can see also the EUS images. Now we are in the body of the stomach. We can see the tip of our EUS machine. We are working with Fuji platform, and in particularly with EG 740 machine, and using Arieta 850. And as you know, we can the improve of quality of images change our possibility and our outcome, in particularly in very challenging technical procedure. So here we can appreciate also the EUS imaging, and in particularly the presence of orojejunal catheter. Now we are ready with Valentina and Ludovica to instill liquid, and before of this procedure, we asking to anesthesiology to inject glucagon. Okay, thank you so much. Okay, are you seeing the images?
We saw the images earlier.
Okay, and so first of all, glucagon, 1 milligram of glucagon, okay, in a bolus. And now we can see the injection of contrast agent through the OEC catheter using syringe. Obviously, we can use also a pump, but we think that we can control using a syringe the amount of methylene blue and contrast agent, because it's not well standardized the amount of one rather than another. Okay. Thank you so much, Professor Gamberini. And now we can see the contrast agent in fluoroscopy, but we can see also that we are starting to distend the small intestine, okay? And obviously we can see also the catheter, okay? There is no a rigid amount of liquid that we can instill. It depends case by case, but commonly 500, 1 liter of liquid is the medium of the amount. Now, blue here, methyl and blue. Okay, obviously we can follow the distension of the small intestine, because normally it is more or less 2 centimeters and is collapsed. And so, first of all, we have to distend our the gut. Okay.
So usually what we always look for at the beginning is to find the target loop, and with looking for the orojejunal tube. And once we reach at the EUS images the orojejunal tube, we always look for having the distended loop actually in a straight position and not horizontal. This usually allows to have less distension of the jejunal loop, but having the correct space to deploy the lens. So this is usually what we have to what we look for. In this case, you can nicely see at EUS images how we obtain a good distension of the loop. And here you see the sparkling and the bubbling, which is always what we look for once we want to verify that we are correctly placed in the jejunal loop. And
we have obviously to check the presence of interposed vessels, and we have also to measure the distance between the stomach and the small intestine. And it is better if it's more or less 1 centimeter. In this case, 6-7 millimeters. Okay.
So I think
now,
usually we use a 20 millimeter lens because there are few evidences that probably it's better than using a 15 millimeters one in having a better tolerance of the diet in this patient and less occlusion over the month. But for sure, these are just data coming from one single study. So I don't know what the chairman and the expert in the connected usually use, but here in Forlì, we always go for a 20 millimeter lens. I don't know if you can hear us and if everybody agree in the choice of the stent.
Yeah, we can hear you very well, and I think that's a very good point. I would agree with you that the 20 millimeter is always a good option, and we actually sometimes we don't have that available in our center, so 15 is still a good alternative, but if you have the 20, I think that would be a good option. And we will also talk about this issue during the Q&A as well, and you can hear more from the experts. We have perspective session, and we can ask our expert what they think. Sundeep, what do you think? Any preference?
Yeah, we always prefer to have a 20 millimeter lamps, but if not, and we are pushed to doing one, I think 15 is also okay. But preference is always 20 if it's available, or arrange it before we actually schedule a case.
I agree with you. I agree with you. If it is possible, 20 will be better than 15, but you can also use 15, obviously, if needed.
So now we insert the lamps into the working channel of the scope. As you can see, the advantage of using this kind of scope is that we have a 4mm channel. So you can smoothly introduce having this larger working channel smoothly in the working channel. And now we are approaching and connecting to a Bio3 machine to engine, and we use a pure cut current FX4.5.
We don't use, in this case, the prevent injection using FMB needle, because we have a good vision, and so we can test just a little bit with the hand of the catheter the pressure that we can obtain with the stomach.
Yeah, so usually you can also, there's also at the beginning of the wet technique, there was the confirmation of the target loop with a 19-gauge needle to see the blue flowing out. So now
we are ready,
and we get into the loop. We disconnected from the power, the lamp. You see there was a bubbling vision at EUS. So now we started with the deployment of the first flange.
Very slowly.
So you always have to take your time for the first flange deployment. So as Carlo is doing, we are deploying the first flange. So here you can see the catheter pulling back. And if you need some more space, you can get some more space. And
it is not open, the first flange. Yes.
So here we have some issues in the opening of the first flange. Sometimes it could happen, and for this, it could be useful to see the X-ray.
Yes.
Here you can see how there's not a satisfying opening of the first flange, which is now with getting better. We need a little bit of force. I don't know how to say to get it opening. Okay. We use X-ray to see if it's correctly open, and now we check for that, and it's correctly open. So we pull back a little bit. We move to the intra-channel deployment of the second flange.
And now we can have the endoscopic view. I can have the entire vision of the endoscopic view. I can retry a little bit my scope. Yes. Can you see the endoscopic vision?
We can see the endoscopic view. We see the mucosa.
Okay.
Okay. And we're waiting. Yeah, here we go. We can see that the you're pushing the scope away from the mucosa so that you see the distal flange.
right.
Okay.
Can you see the
Oh,
opening of the
beautiful. Yeah. Yeah, we can see that.
second plunge? And then we always look for the methylene blue coming out. This is why usually we use methylene blue. We know that in some centers they just inject saline and they not use. So this, I think, it's a preference depending on
There
the
is a
center.
beautiful debate made from Giuseppe Vanella about different tips and tricks about the use of different things during this procedure, and one of that is to use, for example, saline or methylene blue. I think that methylene blue or indigo is mandatory in this procedure because the cost is nothing, and he solve a lot of things during the procedure.
Yeah, so another point of debate once the stent has been deployed is to dilate the lens at first or just wait for self-expanding of the stent. So I don't know the expert what are they used to, but in our center usually we not dilate, but we know that the experiences from San Raffaele in Italy, they're used to dilate at the index procedure. The lamps, I don't know what the other experts are used to.
Yeah, I personally don't dilate after I deploy the lamps. But I can invite our expert panels here, like Shannon, if you're still around. If you can comment on that. And as Professor Carlo is doing his procedure, we've got lots of questions coming in. But we can talk about the dilation. Sundeep, do you dilate after you deploy the stent?
No,
thank you.
we prefer to wait the role of the nature in this case, and so we don't dilate. I would like just to say that the very thin problem that I have during the release of the first flange, it was because the axis of the stent was too much straight, and it is better if it is more oblique. Okay, and so obviously you must wait and to adapt your catheter to permit the release of the first flange. Okay.
Carlo,
Okay.
this is Vinay. Thank you. Thank you very much. That was a fantastic demonstration.
Thank you.
Very well done.
Wendler.
I think we are running late, so maybe if we can take the questions either in the chat box or later during the perspective part of it.
One quick query I would like to ask Carlo for the beautiful demonstration. Did you use pump to infuse and dilate the small bowel, or were you injecting with a syringe?
I think it's disconnected, huh?
Okay. Maybe we can ask in the chat box and he'll answer.
Yeah.
Sandeep,
Yes.
hello.
Hi.
Yes, hi, this is Abid. So probably
Abid.
maybe, yeah, thank you, Vinay Dhir, for the initiative. I think this is one of the great.
Welcome, Abid. Welcome. We missed you during the introduction.
That's a pleasure. So I think once you place an 20 lamps, I think no point to dilate. So this is the usually it will be auto dilatations within a couple of days. So I think dilatation usually will not add anything in this index procedure. I know it's sometimes technically difficult to place a 20 millimeter stent, but usually this is some of the experts they like to have a large stent compared to 15.
Yeah. So Sandeep, I think that well so I think this is what we should do.
I think
we
we'll
have
move to
lots
the
of
next.
you're right. We have lots of questions, but stay tuned, the audience. We're going to answer your questions, but we're going to move to next session video lecture. Would you like to do that, Sandeep?
Yes, thank you.
Okay.
Thank you, Nonthalee, and we'll move forward. We'll try to catch up with some of the lost time, but it's worth the effort. May I invite the next speaker, my friend Michiel Bronswick from Belgium. Michiel is an interventional endoscopist and a senior expert in this field. He's been publishing heavily in EUS gastroenterostomy. He is at University of Leuven and Bonedin. And Dr. Jayanta Samanta, my very close friend from PGI Chandigarh, an additional professor there at PGI, would be the moderator for that perspective. He'll present his perspective after the talk. Michiel, over to you. You can share your slides.
Thank you, Sundeep, for the nice introduction. I'm just going to share my slides here. I hope you can see them.
Yes, I can.
Perfect. So again, Vinay, thank you for the great, Sundeep, for the great introduction, and Vinay for the invitation. It's my pleasure to tell you a little bit about difficult EUS-GE and how to solve these issues. These are my disclosures. Dr. Chan already told us about the good results we have with EUS-GE attaining surgical range efficacy, and we now have prospective randomized data from the Enduro and Goose trials, and also own trial. The eating trial is ongoing, where Sundeep is helping us, and also Jayanta will hopefully soon be on board. And our eating trial is mainly focused on adverse events as primary outcome. So from the Dragoon trial, we'll also know that EUS-GE outperforms enteral stenting, but still mal-deployments remain. Also in these trials, these adverse events happen. And as Dr. Chan also already showed, is that this is one of the major publications evaluating misdeployments and also subdividing them in these several subtypes. And I think one of the main things that we learned over the last few years is not only that we can do EUS-GE, but mainly how to solve these issues. And I think that's the biggest land shift, biggest change in our practice has been the way we prevent and also treat adverse events. If you look at these data, you can see that 467 cases were included, 49 misdeployments happened, but only 5 patients required surgery. This can only mean that we are much better in solving and preventing these issues, and only 4 patients required ICU stay. So again, adverse events prevention and especially endoscopic management are crucial, especially if you're starting out with these procedures. But even so, if you're an expert, you really need to be acquainted with these salvage procedures. Every time we learn a new skill, it is said that we follow the Dunning-Kruger effect. And it means that in the beginning, you know nothing and your confidence is low. And suddenly you reach the peak mount of stupid. My wife says that I'm still a mount stupid. But the goal today is to get you through the valley of despair and get you on towards the slope of enlightenment. And we're going to use a couple of cases, short cases. The first case is a 60-year-old female, gastric outlet due to pancreatic cancer. And here the wireless EUS-GE simplified technique was used. And this technique is mainly used in Europe and also more and more in the US, where we do not use any guide wires or finer needles, just the oral enteric catheter and freehand LAMS placement. So this case, we published it under the lead of Giuseppe Vanella a couple of years ago. You can see already when the LAMS is going in, visibility is poor, and you can see that there was clearly a cautery effect accessing the small bowel potentially, but the tip could not be adequately seen. And we are deploying the LAMS here. And you can see on the EOS image that the proximal flange is correctly placed, but when we inject contrast to confirm our positioning, you can appreciate that there's no backflow of contrast, suggesting that there is a distal mal-deployment or type 1 or 2 mal-deployment. Yes, there is no leakage, but what we can clearly see endoscopically is that there's peritoneal fat coming out through the LAMS opening. This is something you don't want to see, hopefully as less as possible, but you know now that you have a distal mal-deployment or type 1 or 2 mal-deployment. How do we generally solve this? We pull out the LAMS. This feels very counterintuitive, but especially during these 1 and 2 mal-deployments, we pull out the LAMS and we invest our time in improving enteral distension and performing another EUS-GE. You can see clearly here that there was a cavitation sign or smoke sign, indicating good enteric access. And when we torque the scope, you can clearly see that we now do have adequate access. And this is something I also say to our fellows: always try to torque your scope so that you can adequately see the tip of your device. And just to confirm adequate placement here, dilation has been done, and just to check that you're adequately accessed the small bowel. Generally, we don't dilate the lamps anymore because of the data evaluation that we did back in 2020, showing that there is no difference when you dilate or not. You can see here that the old trajectory is being closed. You can do this, but it is not required. So in many cases, you won't find back your access point, and it will close quite quickly and efficiently. Remember PEG placement. If you pull out the PEG tube, the stomach wall can handle a lot of punishment, and these small access points are generally closed spontaneously quite quickly. So if you still see a hole, you can definitely clip it with through the scope clip or over the scope clip. But if you cannot find it back, no worries, it will close. So what do we learn from this case? Always confirm correct placement by torquing the scope, checking the tip before you commence LAMS deployment. Actively look for mal-deployments. And if you have difficulty, take your time and try to optimize distension, use antispasmodics, but also it's worth checking your catheter. If you do not get a nice distension, check your catheter. If it's placed a little bit too deep, you get downstream distension. So sometimes it is worth just pulling back on your orogenital catheter to have more adequate distension. Also, patient positioning can help. If you sometimes go to the left lateral positioning, this can also help in getting a better apposition between the stomach and small bowel. And also timing is sometimes interesting. So if you start injecting the small bowel, especially at the beginning of injection, you get a little bit of elasticity, which increases the diameter. So timing when you're inserting the lamps is also important. And we also showed that the urogenital catheter can be used for confirmation of leakage and adequate placement. You could also see this very nicely by the case just performed by Carlo Fabbri and Cecilia. They also went for a more longitudinal approach, and this is also what we do. When you're choosing these more longitudinal small bowel loops, you get more runway to safely place your lamps instead of going for these more axial morphology loops. You can see that it's certainly feasible, but if you have the choice, please choose the longitudinal approach. Something also nice to know is that if you experience distal flange misdeployment, you can recapture your device. You only have to break off this latch over here, circled here, and you can freely move up and down your device. It has to be said, it is more difficult with 20mm lamps, but especially for smaller size lamps, this is a nice way of recapturing and reusing your device. So again, for type 1 and 2 misdeployment, our main approach is lamps extraction and redo EUS-GE. If we quickly go to the second case, this was a live procedure also provided to me by Giuseppe Farnella from Milan. Malignant symptomatic gastric outlet obstruction, and there was already a previous attempt at EUS-GE, a type 1 misdeployment, which was closed by OTC. And I'm not envious of the endoscopist because this means that there's already an OTC in place at the location of your desired EUS-GE. So very challenging. And you can see right away that the device is already introduced, but you cannot adequately see the tip. And it's unclear whether there's intrajejunal access. The stent is being deployed, and you will see that it's very difficult to see whether the distal flange is actually inside the small bowel. The distal flange has been pulled towards the stomach as it should be, but then whilst the proximal flange is being deployed, you could see a nice wave of blue dye coming. So there was enteric access, And this is something I also wanted to comment to Dr. De Angelis, is that yes, blue sometimes help, but it can also give false reassurance. So in this case, there's blue dye, but there was a maldeployment. So you could clearly see here the small bowel serosa, meaning that we probably had a type 2 maldeployment with small bowel injury. So they're trying now to insert a guide wire through the same EUS scope inside the small bowel, but you can see that the guide wire is pushing away the small bowel. This is, by the way, also the reason that we don't use guide wires anymore for EUS-GE, because it tends to push away your small bowel. And they now have switched to a double channel scope. And they're using a forceps to capture the small bowel to allow for small bowel re-access. Disadvantage of this approach is that you need a double channel scope, but I'll come back to that later. And they're using a needle knife to re-access the small bowel and insert a guide wire. Something which is also important to know is that if you see that you have a distal maldeployment or type 2 maldeployment, please keep your introducer or your introductory device in there. So keep your cautery tip in the target organ. This will allow you to place a guide wire, and you still have a chance to do a lambs and lambs salvage. So now a guide wire is being introduced. You can see that they're using a more stiffer guide wire. I think this is a JAG wire, 3/5 wire, a little bit stiffer than the classic guide wires that you use. And this is also a tip, use stiff guide wires because it allows you to introduce these devices more easily. Tract dilation is being performed, which then allows us to introduce a new lens covering the distance between small bowel and the transgastric trajectory. So you can see the new device going in, the distal flange is deployed, and it is being used to actually oppose the two layers again, and a nice lambs and lambs salvage is being performed here, bridging the gap. And it's also important for this last step to take a little bit of distance to allow for the proximal flange to really come back. And you need to pull quite hard on this. The audaxials can handle this kind of traction, and you will need it to actually bridge this gap. What do we learn from this case? Deploy only when you really know that there's an intrajejunal access. For lambs and lambs, you need small bowel access or re-access. A delivery device can certainly aid in guide wire advancement. You can see it also here in this case where we had a maldeployment for gallbladder drainage. If you leave the introductory device in there, you can still leave the guide wire behind to allow you to do salvage procedures if required. And a stiff guide wire and an additional working channel are certainly helpful. So if you have the resources, this is definitely something to invest in. Something we should not forget, and which is really important, is to allow also for CO2, excess CO2 to be drained. So you can see here that there's a capnoperitoneum. Sometimes your anesthesiologist will already tell you that breathing is more difficult, or they see CO2 levels rising. It is really important to desufflate the patient here. You can use the expensive Ferris needle, but we tend to use just a normal intramuscular needle with some saline in there. You pull out the plunger and you have your own water lock. Really important to desufflate your patient, because otherwise the patient will awaken and will still end up on the OR table because of severe pain. Coming back to the double channel scope, very nice if you have it. If not, know that there's also a accessory working channel available that attaches onto your scope externally. A short third and last case, this was a 60-year-old patient with a gastric outlet due to chronic pancreatitis and was deemed a non-surgical candidate because of a large venous collateral circulation. And we are seeing more and more of these cases. I just sent it to one of our attendees, is that we see more and more of these benign cases of pancreatitis related goo. A couple of weeks later, patient comes back with diarrhea, and you can already clearly see it. there's a intracolonic placement. Or despite that we thought that we were in the small bowel, as you can see here, the lambs dislocated or was placed incorrectly, and you can see intracolonic placement or a type 4 maldeployment. In these cases, we tend to leave a short period of time to allow for a tract maturation. We pull out the lambs, close the defect, and perform a new EUS-GE like you see here. So no surgery required for these cases. These patients mostly present with late symptoms, and you can perform a endoscopic salvage provided you leave a little bit of interval for tract maturation. Again, does not require surgery. And one of the risk factors which we've seen is that if you need prolonged saline installation, it becomes sometimes very difficult to distinguish bowel structures. And of course, EPAS, or a new balloon catheter from Shannon Chan from Canada, will perhaps already solve some of these type 4 maldeployments. So again, just to summarize, prevention is definitely the best cure here. Use a standardized technique doing EUS-guided gastroenterostomy, either West or EPAS, something standardized. Don't rush, take your time, use the correct settings, and don't deploy if you cannot confirm the intrajejunal position. And remember that you can always reintroduce the device if you do not see the device adequately. Really short about maldeployments. For type 1 and 2, we prefer lambs extraction and new EUS-GE. In experienced hands, lambs and lambs or nodes can certainly be considered. For type 3, this is much more difficult, and I would propose to only do these kinds of salvages if you're really experienced and have the required devices available. And for type 4, you now know that you can perform a delayed EUS-GE after fistula closure. I thank you for your attention, which leaves me also to invite you to EUS Skyline, which is held this year, December 5th, where we will be transmitting all these nice interventional EOS cases as well. Thank you all.
Thank you, Michiel, for wonderful talk and nice explanation of the cases where you had the difficulty. May I just ask a quick question? When you have a gastrocolostomy, do you close the gastric end or the colonic end or both with the OVESCO?
I must admit that we only close the gastric side. I know there are colleagues that close both sides. I think it can be considered. No data to back either approach up. I think what we see also when we pull out the lambs in benign cases is that these trajectories close quite efficiently on their own. So I think an approach which requires the least amount of money would be most desirable.
Thank you. Thank you very much. We'll quickly move on to the next talk by Dr. Jayanta Samanta, the perspective on EUS-GJ complications and adverse events. Jayanta, you can share your slides. Meanwhile, I request the audience speakers to...
I think I was just supposed to just discuss on the perspective.
Yeah, perspective, your perspective, sorry.
From what Michiel has discussed, right? I was supposed to...
Yeah, perspective. I'm sorry.
And you have to give your views.
Right, sir. Right,
perspectives are basically personal, very personal. No literature, your own experience on these complications.
Absolutely. So I'll great talk, Michiel. I think I'll carry. I'll just add probably a few points with whatever Michiel has talked about. He has already talked about like in the live case that we saw. So prevention will be obviously the key aspect. So for prevention, one important aspect is the landing area. So we need to understand what size of lamps we're using. So let's say we are not getting a good dilatation. It's always preferable to go for a 15 rather than a 20 and then land up in trouble, because the 20 will require at least 39 millimeter of a landing area. So that is one of the key aspects that if you're not getting, sometimes it can happen, it can frustrate you. You're not getting a good dilatation. Then you need to wait. Either you wait, you use good amount of glucagon, and if you're not able to get that, then at least use a smaller size lamps and kind of bail out that situation. Second, obviously, Michel has kind of pointed out that when you're puncturing, you use a good cautery. So what we usually use is 100 to 120 watts with 5 effect size or a 3 effect size that you use. Most important point over here is to not push, but to burn through. So what happens is you push after you have switched on the pedal, rather than pushing and then trying to, beginners always do this mistake where they try to push and then do the cautery. That leads to a tenting, and that tenting can lead to, you may have a false impression that you have actually punctured the jejunum, but because jejunum is such a soft and malleable structure, if the two walls can get opposed, and you might have a feel that you have actually kind of gone through. That is important, and that is the reason why probably Michel and even Professor Carlo Fabbri had shown that water boiling effect is a very common thing that we kind of look for, that we are entering into the jejunum, that water boiling effect will be there. So then we know that actually we are inside the part. Fourth important point obviously will be the colon is always coming in between, because if you remember our anatomy, that when we are trying to puncture, 90 or majority of the time what happens is we are going from the posterior of the wall of the stomach, we are going through the transverse mesocolon and actually puncturing the jejunum. So what happens is invariably sometimes the transverse colon will come. I think myself and Dr. Sundeep sir was doing a live case a week back, and this colonic loop was consistently coming. So we need to be very careful that colonic loop has to be avoided. Most important on top of that is, if you keep on going and insufflating more and more fluid, you are not getting a good dilatation. Sometimes what can happen is once your IC valve opens up, suddenly the whole of the colon will fill up. This has happened to all of us, I believe, at some point of time. And then all you see is a hugely dilated transverse colon. You have to be very careful to understand the difference in the US image between a transverse colon versus a jejunum. With jejunum, you will see those valvulae convantes, which will not be there. And obviously, when a lot of stool is there and the fluid has gone in, so the water there will be more turbid. If you see the live case, you'll see that it is more anechoic, the fluid is, because it's in the jejunum. The moment it is in the transverse colon, the water will be more turbid, and you'll be very sure that this is colon and not the jejunum that you're puncturing. Fourth important point will be obviously, which Michel has kind of pointed out, that the transverse versus longitudinal, we always prefer a longitudinal axis so we can go very smoothly inside. If there is a kind of a type 1, you're trying to create a type 1 block, let's I think I punctured with Sundeep sir. We had punctured once, so it was not into the jejunum. So then we kind of took it out and then kind of localized well, and then kind of went in, deployed the stent, and then we again went in with an upper GI scope, try to find out where the gastric rent is, and you can close it with either Ovesco, as Michel has kind of shown, or maybe just a routine clipping will be do. Some of the important points is also there is about the ascites, because there has been some data has come up where, because some of these patients can have ascites. So ascites is one problem where what happens is, because as such the jejunum is mobile, on top of that, if there is ascites, it will again start floating away. So that is one of the problems. So sometimes what you can do is you can antecedently do a paracentesis, try to get rid of the fluid as much as feasible, and then try to puncture. But you have to be very careful, because once you start puncturing, and if there is slight amount of jejunal wall movement, then it can start floating away. I have a very good video where my stent was barely able to hold the jejunum because it was starting to float away.
Jayanta,
yeah, hi.
Do you think there's still, this is a very unpopular question, but don't you think that there's still a small niche for patients to get the enteral stent? If there's large volume of uncontrolled ascites which you cannot drain, and it's in between the small bowel, you cannot get rid of it.
Yeah, absolutely.
Sometimes, and I think this is also an important point to make for people who are starting out with EUS-GE, that if you do not have the backup, or you cannot send it to anyone else that can do EUS-GE, there's nothing wrong with placing an enteral stent. You will still help a large portion of patients. So a very sexy EUS-GE, but not at all costs, please.
Yes, absolutely. Great point, Michel. Yes, absolutely correct. That if you are finding it difficult, you do not see a position, sometimes there can be anatomical defect. Some of these patients can have peritoneal carcinomatosis, because of which there is an altered anatomy of the whole jejunum and all. So these things are very key aspects where it is always better to have the safety of the patient rather than your ego trying to beat over it, right? So that is hands down for any kind of intervention, including EUS-GJ, I guess. And one more important thing I would like to point out is that the stent opening, like you saw in this live case also, it was taking some time for the stent to open. I think Sundeep sir is witness to that. So but after I punctured, the stent took almost a minute to open. So all you need to do is keep a patience. You know you're there, but sometimes what can happen is because there is a lot of valvular conjunctivitis can get trapped inside. So as a result, you wait for the stent to open. Yes, sir. Yes, Professor. Yes.
Khalid, please.
Yeah, so that one thing about the stent opening, like when we do the burning and we're over enthusiastic, the tip can get hung up on the opposite wall. So have to be careful about that. If the tip get hung up there and you try to open, it does not open. And if you, what I think in the live case, if you paid attention, when they were trying to open, Carlos was trying to open, the opposite wall was being pulled back.
Absolutely.
So what was happening there is the tip was hung up on the opposite wall. That's why it took a little bit time to open. And the second thing, Jayanta, you already mentioned very well, is like even though one of the biggest disadvantage we always say is of the EUS-GJ is the anastomosis is small as compared to the surgical. That's why we want to go for a bigger stent, but gotta keep in mind for a bigger stent to open, you need a lot of space. You need literally 4 centimeters of space for distal end of the 20 millimeter stent to open. So you gotta keep that in mind. But this opening of the stent could be either the flange, there's not enough space, it's hung up in the proximal portion and trying to decide if I should open into the jejunum or open into the peritoneum. That would be sometimes you hung up on there. If you feel like that is the point, then you gently push it in instead of pulling that back. Unlock the lower part and push that in. That will go in. So these are certain nuances. It happen, come with the experience, but all excellent points there.
Absolutely. Great point with that. If you do not have enough landing space, we do it even for CDS and other places as well, that you do a kind of a double exchange. So you push the catheter, gradually release the stent, push the catheter, gradually release the stent so that you are well inside the lumen. Yeah, absolutely. Great point. Yeah.
This is nothing to do with your talk, Jayanta. There are lots of questions. Those who have spoken already, who have given a live demo, please go to the chat box, answer the questions. Thank you.
Right.
I think we'll move forward. Jayanta, thank you very much for the wonderful perspective. Thank you, Khalid, for your comment. May I request Nonthalee to introduce the next person in line?
Sure. The next person is supposed to be Rajesh, but I think Rajesh cannot be with us today. So I'm actually going to ask Sridhar to give his perspective on difficult GJ. And if you have come across any questions that line up, I think we have about 30 questions, 20 have been answered. Thanks for the experts who answer. You can, give your perspective, or you can pick any of these questions for you to answer. If you want me to pick the questions, I could, but go ahead with your perspective first.
Okay, thank you, Nonthalee. So few points I think I've also noted down, and I must say excellent cases by Michel. So I mean, all 3 cases were actually very good cases, something that you commonly encounter in practice. But fortunately or unfortunately, we don't have the luxury of often opening a second LAMS, at least in our setting. So if you place one LAMS and you mal-deployed, you're doomed, kind of, because it's costly and you typically do not have a second LAMS. So what we typically do, at least what I think often has worked, at least in a type 2 mal-deployment, would be, if you can attach suction to the nasojejunal tube that you've actually placed, it often helps. Sometimes it helps if you actually punctured through the jejunum and still mal-deployed, it will kind of help in the healing, and then maybe you can retrieve the LAMS, arrange for a new LAMS, or place an enteral stent alternatively. The second thing, at least I think the loop position, I think Jayanta already spoke about. But the only thing, I think there is a certain access to it. So yeah, 1 to 7, or if you're doing it the European way, maybe from 11 to 5 or 10 to 4. And lastly, I think one interesting area that is often emerging now is benign, gastric outlet obstruction. A lot of people actually putting EUS-GE in the benign setting. I think Michelle also showed a case of chronic pancreatitis wherein they've actually done this. We've done a few cases ourselves, and they work rather well. And there is, of course, the opportunity of reversibility wherein you can actually pull the lambs out, and if the so-called primary cause of the gastric outlet obstruction recovers. But then again, I'm still wary because there's not a lot of data to use this technique in benign, and maybe I think this is going to be something that you will do in a situation only where you cannot do anything else. And lastly, I think with regards to too much insufflation, I think sometimes you may it's always better to pass the scope inside before you start insufflating the bowel. You start and you take your position, maybe use fluoroscopy and look at the limb. Try to face the so-called end of the the oroenteric catheter, and then start insufflating rather than insufflating before you introduce the scope. That would actually save you a lot of heartache, because you often end up over insufflating the bowel. You will end up trying to find a loop in the whole mess of loops that you're actually seeing. And like Jayanta said, you may often actually have the colon also distended if you've already started insufflating. So that often becomes a problem, and it's always safe to insufflate only after you've introduced the scope, and then you actually know which loop of bowel you're actually trying to puncture, rather than insufflating before you introduce the scope. So I think that's my perspective, and I think only you can ask me any of the questions that are in the chat box. I'll be happy to answer
Yeah,
them.
maybe a couple. What are the common causes of failed EUS-GJ, and how do you overcome that, or how you prevent that?
So technically, I mean, the challenge is, of course, in the West technique. So the EPAS, I feel, is slightly safer. You know which limb to puncture. You're dilating that exactly. And the West technique often has challenges because, like we've already discussed, all of us face technical challenges, and like Michelle already showed, these are the challenges that you typically face, wherein your your loop may not be appropriate. And like Jayanta already said, you may tend, invariably thinking that you've actually gone in and mal-deployed. So technical aspects, there is a clear learning curve. I think Shannon already said 25 to 40 cases, absolutely true. So you will have complications in the first few cases that you do, but as you cross the learning curve, I guess once you cross the barrier of 50 cases, your complications, I think I've not had any complications after that. So there is definitely a learning curve. So initially, I guess the first few cases, maybe the first 20, 30 cases, you have to be rather careful. And I mean, clinical failure, of course, choosing the patient, it's often difficult. You may have patients who've had a very dilated stomach, who have gastric atony. Despite relieving the so-called obstruction, they may not be so-called clinical benefit. So that, of course, is rather unpredictable, and you'll only find out once you've actually placed the stent. I think Jayanta.
Thank you. Yeah, Jayanta and
Can
Vinay. Maybe
I add,
Jayanta first.
yeah. Can I ask one
I'll
for?
Sorry.
Yeah. So thank you. So I would like one point for a failure. So rather than technical failure, so I think usually the time of deploying the lamps, generally people, they count the time is very crucial. So you have to be very slow, and you have to take your time to perform the procedure. So the ego additionally to the quick people to perform the procedure. So this is one of the cause of failure usually. So they consider the time of the procedure is a matter. I think is the time is not matter. You have to take your time. You have to take your time. You have to have a good access, and you have to think about the safety. This is one of the big failure of the expert people. And you see some people sometimes very expert, and they can do major complications on live procedure.
Right.
Yes.
Thank you.
Can I say something here?
Sure.
Yes, go ahead.
I think one issue which probably has not been discussed is, and I feel it is very important, especially in identifying jejunum versus colon is contrast injection.
Yeah.
So if you inject contrast, you will never go into the colon. So please inject little bit of contrast along with your methylene blue and use your glucagon or buscopan at the appropriate time, and be ready with your scope before you start instilling the water. If you do these three things, I think going into colon, I have never had that problem because I can see the jejunum with the contrast. So that was the point I wanted to make.
Thank you, Vinay. Jayanta, and then Cambia.
No, I agree completely with Sridhar on all the aspects except one, and that is mastery, proficiency, everything apart. Even now, when you do after crossing 100 GJs, you still keep a beat when you're
I
pumping,
agree.
right?
Yeah, you have palpitations.
You cannot bet that. I mean,
Yeah, you have palpitations. That is sure. Yeah, that is sure.
I just had a problem last week. So after doing hundreds of cases, so it happens.
Cambia,
yeah.
So just to follow up on Dr. Dhir's point, it's inevitable that at some point, particularly in the early learning curve, that you'll have trouble. And what we emphasize with our trainees is that if you ever end up deploying a LAMS into the colon, and this may happen, it's really vital to leave the LAMS in there and to complete that procedure rather than pull the LAMS out. The small bowel can be forgiving. It's generally a sterile environment, but the colon will not give you that liberty. You're going to have peritonitis and trouble. And just one little point to add is, the Axios system has this little nubbin at the very tip. It's a long channel that runs the entire length of the Axios. And so one of the things that's very, very helpful and we use quite often in these dicey situations is to thread a wire through that and halt it halfway through the Axios, deploy the Axios, and then complete threading the wire. So that eliminates one step. And if your Axios ends up falling out, then you still have wire access to the small bowel.
Very good. Thank you. So I
Let's
think,
go ahead.
Sundeep, it's about good time to move to the next session, which is the last session. You want to introduce our next speaker?
So may I request now Cambia and Hassan to come back and give a talk on EUS-GJ, and then we'll have the perspective from Sudipta.
Cambia has a very interesting technique. I think that's a fantastic one. I only read about it, so I want to see it. Cambia.
So, innovative indications for EUS-GJ video lecture from Cambia. Yes.
Sorry, I'm trying to share my. Is this showing up?
We can see that. Just get it full
Okay.
screen.
Get it to full screen. There we
Yes.
go. Is that better?
Go ahead.
Okay. Well, thanks again, Dr. Dhir and the organizing committee for giving us this opportunity to discuss something that we hold quite close. So it's been an excellent sort of conference so far. We've spoken about EUS-GJ primarily for malignant obstruction and some use for access. But in today's talk, we're going to sort of discuss how we are trying to move this forward and push the boundaries on EUS-GJ with work that we're doing here at CIE. So I have no disclosures. I'll start by simply saying that, interventional endoscopy, and I know many on the panel will agree with me, is the next step in the evolution of anatomical reconstruction. We're moving from open surgery to MIS, and that took us about 40 years to do. MIS to robotics, another 10 years or so. And, with the endorobotics platforms sort of being developed, many would argue that NOTES approaches are going to be the next big thing. Now, we've already gone from sleeves and revisions to ESG and TOR. We're doing anti-reflux procedures endoscopically. Surgical necro that used to be this horrendous procedure is turned endoscopic thanks to the LAMS. And surgical gastroenterostomy, by and large, is being now sort of replaced with EUS-guided approaches. So, without just in an effort to make up time, we'll quickly go through what it is that we're doing. And our experience with EUS-GJ and benign disease really started with using EUS-GJ for post-surgical duodenal leaks. And this was our very first patient that presented a few years ago, 82-year-old female, acute abdomen related to an NSAID associated duodenal perforation. She underwent open surgery with an omental patch, which is quite standard for these patients. If you're not expecting a leak downstream, they don't typically do a pyloric exclusion. Post-operatively, in her third or fourth day, she started to develop large volume sort of output from the JP drains, indicating a leak that was confirmed on CT scan. At week 2 already, you have a hostile abdomen, matted abdomen, and most surgeons don't want to go back in there. It's sort of all frozen and difficult to deal with. So some of our colleagues at an outside institution attempted endoscopic closure, and then they referred the patient to us. So getting together with our surgeons, we sort of tried to figure out what we could do and how we could divert the acid-rich stream away from that duodenal bulb perforation. And we figured that we already have the tools and technology to do this. So our first step was EUS-Guided GJ using the standard described techniques. And what that does is it partially diverts the gastric flow away. And then we, in our second step of the procedure, what we do is endoscopically place 2 layers of sutures at the pylorus and shut the pylorus down. And at least conceptually, what that does is completely divert, the acid-rich stream away from that perforation site, promotes sort of this homeostatic environment of higher pH that promotes clot formation, granulation tissue, and healing. And this is just the technique that we use. It's 2 layers of sutures, 2 of proline endoscopically. And typically after we've done that, we start patients on a liquid diet either the same day or the very next day. We monitor the JP drain output, and we typically discharge patients home and ask them to monitor their JP drain output, of course, that we check with clinic follow-ups. Our goal is to get a 30 milliliter or less output of serosanguinous fluid and or 6 weeks. So that's kind of the threshold that we look for. And this is the typical sort of a picture that we see on the JP drains. Immediately after the procedure, output typically falls dramatically. And then over a period of time, that output slowly dwindles down to when it approaches, 30, 15 cc's. We then bring these patients back for a second procedure, a second look, and then we open up the transpyloric sutures, look for the duodenal perforation, make sure it's healed down, and then just retract the lambs, take it out. And for most of us that do this, it's fair to say that the defect ultimately just closes down. And what you end up with is just restoration of normal anatomy and the bypass reversal. So here we are, you're seeing a transmural defect with those blue arrows. We inject contrast into the patient and you see extraluminal sort of extravasation. We then do a GJ using very standard West technique. You're placing a lambs. We didn't get the good window that was previously shown, but we place the lumen opposing stent. You're sort of deploying the distal and then the proximal flange. You're seeing this beautiful blue sort of gush of methylene blue confirming placement, and now we are just suturing. I kind of move this forward just to make up time, but it's important while you're suturing to sort of maintain a short position, and sometimes just angling your fluoro table towards you will allow you to maintain a short position, kiss the lesser curvature of the stomach while you're suturing, thereby preventing excess pressure on the freshly placed lambs. So we go ahead and we're suturing. Here you see we've placed both layers of sutures. We inject contrast. You see nothing go past the pylorus and all go into the jejunum past the lambs. This is the reversal procedure where we go in and we see the sutures remain closed. Sometimes the second layer will come opened a little bit, and that's okay. What we do is we're just cutting the outer layer of sutures. And what that does is it quickly sort of restores the pylorus to its native state. In this case, we're taking a quick peek with an XP scope through that area to make sure that the defect is closed. And here you see just beautiful granulation tissue formed in the area that used to be the defect. We inject contrast to make sure that's the case. And then, of course, we take down the second layer of sutures. It's very simple to do. You just pull them out. And since we've intentionally not deepithelialized that area, it's very easy to do, and the pylorus sort of restores back to its native anatomical state. Sorry about the choppy video. I'm not sure what's causing it. So we published our first case and subsequently our pilot series. And initially it was 6 patients. Technical success in 100%, no adverse events, clinical success defined by our ability to sort of start a patient on a diet without a dramatic increase in the white count or peritoneal signs, and then send them home in a few days. What we noticed is one patient did have a delayed adverse event. It was just a mucosal bridge that was likely related to an ulcer across the pylorus. We took it down with a standard ESD knife and wasn't really a problem. What we also noticed is about a 10.7 kilogram weight loss around this period, and it's difficult to sort of attribute this just to that bypass, but we strongly suspect it may have played a component. So our current status is 18 patients across 3 centers in the US. Results are very promising, and we look forward to publishing another series fairly soon. So this sort of is a segue to the use of this type of bypassing for weight loss and metabolic disease. And some of our preclinical work in this area, and I'll browse through this fairly quickly, is that we're able to, or we already have the technology to bypass a fair amount of small bowel using a balloon enteroscope. And by doing that, we sort of create a target zone in the small bowel that's much further down than a standard GJ placement that typically occurs in the C loop. And we then place a regular LAMS, we suture down the pylorus, and we restrict the stomach. And so what you end up with is something that looks like a single anastomosis gastric bypass, where we've sort of bypassed, 150 in a long or 90 centimeters in a short version of this. Once the patients have reached their trajectories for weight loss, in about 3 to 6 or 8 months, we typically bring them back, and you take the LAMS out, you restore the transpyloric continuity, and now you've essentially reversed that bypass and left the patient with a restrictive procedure that is going to maintain the weight loss. So these are the just a brief 2-minute video of that. What you're seeing on the left is the overtube balloon inflated and the small bowel sort of pleated just proximal to it. Here we are taking our scope out this modified overtube. In blue, you see the target zone overlying the gastric silhouette. And here we are placing just a lumen opposing stent. In this case, it was a 15, and you can sort of modulate the opening. You can place a 15 or 20, depending on your trajectories of weight loss that are required. Here again, we see that beautiful blue dye come out, and then you simply withdraw the the overtube after sort of deflating the balloon. You suture down the pylorus, and in porcine models with the way the stomach is, this can be sometimes challenging to do. And what you do is ultimately inject contrast to ensure the lack of transpyloric flow and that everything's being sort of shunted through the LAMS. You then go ahead and just do an ESG, a modified ESG, if you will, to avoid the lumen opposing stent. And here you see restriction within the stomach and lumen opposing stent that lies immediately past this. And here you have complete shutdown of the transpyloric flow. We confirm this on fluoroscopy, where you see the contrast comfortably flow through. So we published our initial sort of animal studies. The procedure, interestingly, doesn't take very long. It takes about 2 hours to complete, which is about roughly the time that a surgical bypass would take. With the short overtube, which is about 95 centimeters, we achieved bypass limb lengths of 90 to 95 centimeters. And with the long overtube, that's 180 centimeters. Bear in mind that this is post-pyloric and not post ligament of Treitz, which is what the surgeons see. So you take away 20 centimeters from that. Now, moving on to the next part of this, EUS for benign disease, like was pointed out earlier, we can't really discuss benign disease unless we figure out how to consolidate that lumen opposing stent. LAMS are simply not designed to be indwelling prosthesis. So how do you consolidate that GG fistula? And so we've described this double LAM septotomy, where you basically place 2 lumen opposing metal stents, and you rely on the serofibrinous sort of reaction that forms around those stents, typically extends about 1 centimeter in both ways, to sort of consolidate the actual tissue bridge between those 2 limbs that you can then take down later on. So what we described was a patient with Roux-en-Y with a stenosis of the outlet that we basically managed to eventually sort of do the septotomy procedure and significantly dilate. And this is our first patient that we did. Here you see a sort of a pinpoint outlet from the gastric pouch. We're doing a an EUS-GJ. This time we are doing, this is a de novo EUS-GJ that we're doing approximately 2 centimeters from the native gastro-jejunal sort of pouch here. You see an ultra short pouch, and so it was a little challenging to do. The second lambs is placed through the native opening, and what we're doing here is just suturing them. You don't really have to. This was our initial experience, and we didn't want, we didn't want the stent to pass. I apologize. I'm going to just fast forward this to right here. And so once you've taken the lambs out, what you see is this tissue bridge that we're just dissecting with a standard electrosurgical knife. And once you've reached sort of the submucosal tissue of the small bowel, what you do is just take an IT knife and dissect it completely. And what you eventually find is sort of this dramatically enlarged opening leading to the small bowel. We inject contrast, ensure that there are no leaks, admit the patient overnight for observation, and ultimately discharge the patient. In this case, we shut down the mucosa with sutures and brought the patient back for endoscopy in 3 months. And here you see this beautiful, native-looking gastrojejunal anastomosis. It just looks like a surgical revision would outside of those clips in the area, and you see a dramatic increase in the flow from this area. So the technique can be applied to other areas as well. In Roux-en-Y patients, we were frequently asked to reverse the bypass with lumen-opposing stents due to protein-calorie malnutrition, refractory anemia, nutritional deficiencies, things like that. And frequently patients don't want to have surgery. So we devised a way to sort of turn this temporary LAMS-related reversal of the bypass permanent using this technique. You basically place 2 lumen-opposing stents just next to each other, and using the same technique. And here we are sort of, that's the first fistula that we created. Here you're seeing us create the second fistula using the lumen-opposing stent with an intervening septum that here clearly has 2 separate layers of muscle in it. Deploy the distal sort of flange. Here we're replacing that lumen-opposing stent to try and be cost conscious here. Ultimately, we bring the patient back for step 2 of the procedure. Both the lumen-opposing metal stents are taken out, and that leaves us with this tissue bridge in between. You typically use a Doppler to make sure that there are no significant vessels there. We're describing 2 fistulas. You drop a wire in one of the fistulas, you go through the other, you withdraw the wire, and what this wire does is it acts like a surgical ligature would. So when you pull back on it, it sort of pulls the septum back and isolates it from the posterior wall. You then use a standard ESD knife to sort of dissect it and release it. And so what you end up with is an anastomosis that typically is about 3 centimeters in diameter. Here you're injecting contrast to ensure the lack of any spillage. And you typically bring these patients back in about 2 or 3 months to take a second look. So I'll conclude by saying that innovation typically starts at the fringes of what we think is possible. Use in benign diseases is an exciting sort of area that we're exploring. With a disruptive technology like robotics and magnetic anastomosis being developed, EUS-GJ is going to be more than just palliation. It's going to be sort of this enabling platform for a surgical level intervention. We need robust long-term data. And while these promises are relatively early, trials will ultimately determine what the clinical adoption will be, and collaboration with your surgical and medical teams are essential. With that, I'll finish, and thank you once again for allowing us to participate.
Thank you, Kambis. That was very innovative. May I quickly request Sudipta, who's been waiting eagerly to give his perspective.
Nothing much to give a perspective on all these cases. They have been all out of the box thinking. Absolutely out of the box. There is nothing that I can give a perspective on. In fact, in the first case, when we had to do this, as we used to do a tube gastrostomy with a feeding jejunostomy, that used to be the usual way out for ourselves. Now with this technique, and the other cases number 3 and 4, I probably have to go back to the videos to understand actually what happened. because it happened a bit too fast. My only concern was how patent is this anastomosis? How long does it last?
Kambiz, can you answer that?
Sure. Thanks, Dr. Chaudhary. This is all fairly new, and I can tell you our experience with these double-lamp septotomy is now 5 patients, and our very first patient is over probably 16, 18 months, so a year and a half. I showed you the 3-month follow-up. It looks really good. We've beyond that 3-month follow-up, clinically, we're following this patient. Weight has been stable. She's doing very, very well, as are the others. And so we have no reason to believe that the stenosis is back. In fact, the weight gain has been more than we expected. And we were actually thinking about going back in and doing something like a TOR to actually reduce the size of that anastomosis, from that 2-3 centimeters where it had reached. So hopefully these remain patent, but we're not doing anything to take away what caused the first stenosis to begin with, and so it'll be a matter of time before we learn this.
And as regards your EUS-GJ as a use for treatment for metabolic disease, one quick question: your length of bowel is primarily the position where you do the anastomy is primarily determined by the tube length.
Yes, in the bypass procedure, it is, but double balloon enteroscopy, is very predictable in how many centimeters of small bowel you're going to basically traverse with every cycle, antegrade cycle that you do. And so, we've sort of seen this stand true in the animal models, and it's just as predictable as a surgeon would. The way surgeons do it is laparoscopically. They're just running bowel and estimating 10 centimeters at a time. And so we've reliably been able to get between 90 and 180 centimeters of small bowel from the pylorus when we look at it. And so, it looks very, very promising.
Awesome. Simply awesome.
This is fantastic. Kambi is really, really innovative. Congratulations on thinking out of the box and creating these solutions. We have Shannon here. Shannon, any comments on this?
No, so it's a very impressive innovation and use of the EUS-GJ. So I just have one question about the leakage of pyloric exclusion in GJ, because a lot of the duodenal leaks are leaking bile and pancreatic juice, right? So the pyloric exclusion, it excludes the gastric exit, which can be dealt with PPI and fasting. So I'm trying to understand why that actually helps with the healing, because if you let the patient eat, then the bile and pancreatic juice secretion will be the same. And so I mean, your results are amazing, but I'm just trying to understand the physiology behind.
Thanks, Dr. Chan. This is something that we've sort of given a fair amount of thought to. The duodenal bulb, what we tend to see in patients that we've shut it down immediately the next day is that there is a drastic drop in the output from these fistulas. Originally they tend to be 500 cc's, 300 cc's, but once we shut down the stomach, that's typically producing between 500 to a liter of gastric acid. You've already done away with that larger volume of acidity. So in trying to figure out what is more problematic in that area, gastric secretion, meaning orogastric secretion or pancreatic juices, I think results are in the pudding, where when we do divert secretions away, that these patients just respond dramatically. And if I heard you correctly, you're a general surgeon by training. And so I understand the skepticism, but it probably works in the same way that surgical pyloric exclusions were thought to have worked in. But this is just accomplished in a much less invasive fashion than reoperating the patient. Now, I will say that our experience has grown, and we've moved this down to a second portion and third portion of duodenal injuries. And the way we are doing this is we are doing an ERCP, placing long pancreatic and biliary stents, fully covered stents, and then moving those down into the second and third portion of the duodenum. And that is going to be the next sort of series that we publish. And so there is a way to divert not only the acid-rich secretions in the stomach, and to reiterate that acidity. While PPIs are fantastic, most of us will agree that there's a large percentage, and sometimes, in literature, you'll see 30% of patients that are PPI non-responders. So they're not really this notion that PPIs are completely doing away with gastric acid, not to speak of the large volume that's being generated, regardless of whether it's acidic or not, may not be as effective as we think it is. And that sort of opened avenues for us to explore to see if there are other options we can offer patients. So yes, there's a way to divert the pancreatobiliary secretions, but for duodenal bulb leaks, we've not seen the necessity to do that.
Thank you. Thank
you. I think, Sundeep, we are running.
I think we are at the end of the session. I think we are over on the time.
Yeah, is Claudio around? I want him.
Yeah,
to
he's there. So Claudio and Vinay, you can now sum it up and wind up the session.
Yes, I'm here.
Yes,
congratulations for this session, for sure. This has been a great session. For me, that started EUS in the 80s, when EUS was a radial morphological technique. And we try to understand what we are looking at, and we try to understand the anatomy, the echoanatomy of the structures, to see what we can do today with the EUS, reaching very surgical endoscopic procedure has been very, very amazing and interesting possibility. I take this opportunity to bring you the greetings and the best wishes for a fantastic series of webinars from the European Society for EUS, that is the EGUS-ETS, which is pleased to support and endorse the EUS World Initiative. In this almost 2-hour webinar, a topic was addressed that today represents one of the hot points of modern therapeutic EUS-Guided GJ. And in such a short time, this group of very, very experts has put forward interesting technical tips and tricks and ideas, even with practical live demonstration of the technique. They summarize for us the most recent and salient literature data on the subject and demonstrated the most innovative, very, very innovative indication. Thank you very much, Cambits, for this of the technique. So this was the first game of the challenge conceived and organized by our Vinay Dhir, our host and master of ceremonies, to try to simplify what he has always been considered one of the most difficult endoscopic techniques to learn, if not the most difficult. Alea iacta est, said the Latins. The die is cast. The arduous judgment is up to you all. We look forward to the next games. I think that we have to thank you all, the faculty, today from India, USA, Hong Kong, Italy, Belgium. Thanks to Vinay and all the Indian US Club. Thanks to Boston Scientific, which made this event possible. And mainly thanks to all the online participants and the faculty of the next webinars of this series. See you all online next time. Goodbye. Goodbye.
Thank you, Claudio.
Thank
Thank
you.
you very much. Thank you, Anirudh. Thank you, Boston Scientific, for all the help. And thanks, Nonthalee. Thanks, Sundeep, for hosting this wonderfully. And we meet next month.
Okay. Bye-bye.
And bye-bye.
Bye-bye.